So, hello everybody. Just on time, just 4 minutes late because we waited a bit for everybody attending and coming in. May I welcome you all to this webinar today. We're talking about shockwave therapy. I will introduce myself in a minute when I start the presentation. I just want to give you a short information what's going to happen today. We could talk about what actually shockwave is. We talk about radial and focal shockwave, about the differences when we use which device. Talking about everything in action, what is happening in the tissue, what we can perform. I will show you a lot of cases about what I'm treating in my daily life and practice. A lot of pictures about how it looked before, how it looks after. And then we will have time for questions. Just that you all know, because we have a lot of participants today. It's at the moment we've got 87. Probably some will join us later during the presentation. We will have time for questions at the end. I'm quite sure not for all questions, but after the webinar, it's possible to reach out to me, writing an email or a WhatsApp message, and all the questions will be answered. So this is not a problem. You don't need to be worried about. So I will start the presentation. Hang on, hope everybody can see the presentation now. If not, please, anybody just tell me. Yeah, this would be a good thing. Otherwise, I'm gonna start now. So, short introduction of myself. My name is Alexander Ablass. I've got a message. Presentation works, great. I'm a physiotherapist from Germany. I'm based in Augsburg. It's a city near Munich in the south of Germany. I'm worked with FC Augsburg Youth Academy in the club for almost 7.5 years. Now I'm in charge for First League ice hockey team. They just made staying in the First League yesterday. I'm very happy about that. I'm a member of the Science Board of Sports Medicine newspaper, and I work with the shockwave almost 8-9 years now. So treating a lot of patients every day. And that's why I'm gonna tell you what I'm doing today and give you a short around about shockwave. Nice view of my city. We're talking about the theory in the very beginning. What are the aims of modern shockwave? Basically, we don't need no or less medication. We can avoid injections, for example, cortisone injections. We don't need operations. It's non-invasive, has a low risk level and high effectiveness. So at the end, we've got happy patients and get a successful practice. EMS is the #1 in clinical evidence, not just because they invented radial shockwave, but they're doing research in many years. So more than 50% of all published level 1 trials, clinical trials, are done with a Swiss DolorClast shockwave device. And more than 60 of all these studies show that the biological effects and the cellular effects can be generated with the Swiss DolorClast device we're talking about today. What is the technology behind all this? Why does it work? What is happening? So as you can see on these pictures, when we talk about shock waves, it's a kind of pressure wave. It's an acoustic wave. It's nothing mechanical. That's why we can use it with also many indications. How does a shock wave actually looks like? A shock wave is a sonic pulse that has certain physical characteristics, as you can see on this picture. So what we need is we need a high pressure phase in the beginning, compression phase, so up to 100 megapascal of pressure, followed by a negative phase of pressure, which is roughly about 1/10 of the maximum pressure we had in the beginning, so about 10 megapascal. So this are numbers you should keep in mind, and whenever you get offers from other devices, always check about the pressure, maximum pressure, and especially the negative pressure phase, which we call the tensile phase. So the stimulation of the tissue by a shock wave starts with the compression phase, followed by the negative phase. That's what we already had. We call it tensile phase. This tensile phase releases the energy from the compression phase. So 1/10 in negative phase is relevant for how much energy we can deliver basically to the tissue. And we call it the bubbles appearing in this phase, cavitation phase, and which are basically the effects of the energy restitution in the tissue. High cavitation level is a result of a high amount of energy density delivered by the shockwave device. A radial shockwave is working as with a projectile inside, which accelerates the projectile up to 90 kilometers per hour, applying this to the applicator who is fixed to the piston. And this kinetic energy is converted into acoustic pressure waves. These are the characteristics we already mentioned. So we have got in number one, the high compression phase, the positive phase. As you can see on the picture on the right, looks the following. And we have the negative energy density, the tensile phase, which looks like this, where you can see the small black dots, which we call cavitation bubbles, which are generating basically the effect in the tissue. I also have a video where you can see compression phase and now the tensile phase with these cavitation bubbles. As we check and look everything up in for the focus device, yeah, you can see it's completely different. Yeah, we have got more than 1,000 piezoceramic crystals, which have a special alignment in the handpiece. With a voltage supply, not a pressure supply, and we have a gel pad, which defines how deep basically the focus is going into the tissue. In this case, we have the midpoint focus for 40 millimeters deep, and the penetration can go up to 8 millimeters, whereas the radial one has a penetration depth of 40 millimeters. So the same picture as we had with the radial one. We have got number one, the positive energy level again, the compression phase, which looks in the focus device different. And we have negative energy density, which looks in the picture like this. So we just reach a high amount of the energy in a certain spot. If you look at the video, you can see the wave leaving the piston, the handpiece, and then you can see when we reach the primary penetration, it stops. Everything what I'm going to tell you now about how does it work, what is happening in the tissue, is everything is level 1 evaluated. One of the most important guys doing this is Professor Christoph Schmitz. So in this study, they could show us that the effects are mediated by cavitation, small black dots. If you have a look at the different kind of handpieces available on the market, you see the differences. You can see just taking 4 bar at 15 Hertz frequency, you can see small black areas which demonstrate and show us the cavitation bubbles. The problem with this picture is that the cavitation bubbles are lying over each other. So we don't know the exact number of cavitation bubbles we can find. So if we check the total amount of cavitation, we need to count them. Yeah, Professor Schmitz, I already mentioned, was involved. So on the right picture, you can see the counted amount of cavitation bubbles. If you now compare these with the two main competitors of EMS, we leave this one out. If you just compare it, you can see that the EMS Evo Blue device and the piezo handpiece are providing most of cavitation which is possible at a frequency of 15 Hertz and 4 bar pressure. In total, that means if you see that other devices are even able to provide 5 bar pressure, yeah, you can see that the energy output of these devices cannot be predicted with the air pressure we put into the device. So it's about the technology which leads us to the hand piston. So the piston needs to be able to transfer the air pressure which is going into the device into a high energy output, which is a special technology, and the patent lies on EMS. If we now concentrate on another study, one of the most important studies done in the last 2 years, which compared the DolorClast radio shock waves and the Storz MasterPulse 200. If you have a look, we have a look at the DolorClast first. You can see that the energy which is delivered at different frequencies and different pressure inputs could be held constantly, almost at all frequencies. If you now compare this with the Storz MasterPulse 200 Ultra, for example, you can see that even at 5 bar, with a 5 bar, you can see that the energy is decreasing immediately after the almost 2 or 3 Hertz frequency. So you see the energy delivery is decreasing enormously. We have got a loss about 92% at maximum output and frequency levels. We come back to this picture in a minute. First, let me say one important word about this study because it's connected to these pictures. So we know that high energetic radio shockwave in comparison to low energetic radio shockwave is leading to better results. So we need high energy outcome to get perfect results and good results. And we also know out of this study that lower energy outcome cannot be compensated by increasing the total amount of impulses. So just doubling the impulses to reach the same energy outcome does not work. We need high energy with every single shot. If we now compare this to the study list we have, 90% of these studies with a DolorClast which were published in the Pedro database, have an energy flux density of approximately 0.1 millijoule per square millimeter. This number is very important because a lot of people always say their shockwave device can provide, can generate these effects, which basically EMS is proving. And if you compare this with the picture now, the most important picture, it's both devices over each other. You see the number of 0.1 millijoule per square millimeter energy delivery as a baseline of 90% of all studies. What you can see is that the Storz device can't deliver at all pressure inputs and all frequencies, never reaching the minimal energy we need to get these results. So whenever a competitor or other devices claim that their device can generate one of these effects, which were proven with the DolorClast device in the literature, this is just not working because they just don't reach the minimum energy level. Just as a comparison, I made 2 little videos. Yeah, it's just about making cavitation visible. So we take the highest settings of these devices. You will see on the right picture, the EMS device. Now you see the EMS device on the left side. And now we put these different hand pieces into water. The right side is EMS, and in the other picture, the left side. And now we can see cavitation. Okay. We see more cavitation with the EMS device here and with the EMS device here. So we can just make cavitation visible. And the same is with the focus device. If we have got the Swiss piezo-clast on the left side, we can see the maximum energy pressure delivery is 110 megapascal, above 110 megapascal. And we have the negative phase. the negative phase, which is about -20. On the right side, 2 times higher pressure. On the right side than the stored stool lid has with 40 and -10. So when we know that we need a high negative phase to generate the energy, yeah, we see which one is stronger. The maximum energy output of the radial device is 0.28 millijoule per square millimeter, and the focal device 0.55. The penetration radial up to 4 centimeters, and the focus device up to 8 centimeters. So radial shockwave, superficial applications, perfect. 90% of all tendons are located less than 50 millimeter under the skin. So this is #1 decision for the treatments. Large surface, large muscles and muscle chains, faster treatment time. We can be 3 times faster than with the focus device. Yeah? Why choose the focus then? We can reach deep applications, high energy applications, precise targets, and hypersensitive patients. So let me say one word, because you will see a lot of cases not really defining which device is used, or you see a lot of cases where 90% is used the radial device. Both of these devices are necessary. So we are talking about what is happening in the tissue. What are the effects of shockwave? We get pain relief, pain elimination, increase of blood circulation in the surrounding tissue, inhibition of inflammation, activation of reparative processes in the tissue, and the muscle relaxing effect. Let's talk about pain first. We have got neurogenic inflammation and we've got pain. How is this connected, and why is it important to treat these two things? Substance P increases the sensitivity of C nerve fibers and leading to an increase of this pain signaling we have. With this, the release of substance P is the response by the C nerve fibers. And this substance P stimulates again histamine, vasodilatation, and increase of nociceptive signaling. So whenever you feel pain, always follows neurogenic inflammation. If the neurogenic inflammation is getting high, we get pain. With this pain already causes neurogenic inflammation. So we have got a pain circle, which we have with almost every injury or process running up, a negative process running up in our tissue. So first, before we can increase or start the healing process of our tissue, we need to decrease the neurogenic inflammation. It's a self-stimulating mechanism that needs to be blocked because the neurogenic inflammation is blocking the healing process. And also the expression of scleraxis, which is a very important protein which we have in every phase of tendon repair. So scleraxis can be found in every development of tendons. It's the earliest detectable marker for differentiating tendon cells. Shockwave inhibits the release of substance P and therefore blocking the neurogenic inflammation. Whereas drug-induced inhibition, like local anesthetics, they inhibit healing. Corticoids inhibit healing. Yeah, these two are just symptomatic treatments. None of them inhibits the release of substance P or the suppression of neurogenic inflammation. It's just a short-term effect we have on these tissues and these problems. How I explain it to my patients, this I think is the most easiest way because it's exactly the same mechanism we have. Eating a red hot chili pepper is like using shockwave in a way. Yeah? If you bite in a red hot chili, first your mouth burns and then is getting numb. That is caused by capsaicin. First it burns, then it goes numb. The same is the pressure wave therapy or shockwave therapy doing. Yeah, pain first, then recovery. If we have less substance P, pain is going down. If we have less substance P, neurogenic inflammation is going down. Neurogenic inflammation is going down, then we get healing, release of growth factors, stem cell activity. Our indications for shockwave therapy: the basic things, the classic ones we have: calcifying shoulder, Achilles tendinopathy, tennis elbow, heel spur, all other antiosiopathies and tendinopathies we have. But there are many more. Yeah, if you look at just a picture, this is just a short overview: trigger points, lymphedema, cellulitis, Osgood-Schlatter disease, wound management, Achilles tendinopathy, plantar fasciitis, all these. Well, we also need to talk about contraindications, of course. Treatment over air-filled tissue, like lungs or intestines. Treatment of torn tendons, treatment of pregnant women, treatment of persons under the age of 18, like thrombosis, local thrombosis is a contraindication. Of course it is, like every other treatment. Treatment of patients with oral anticoagulants, tissues with local tumors, and one of the most important contraindications, like local cortisone injections. At least we need to wait 6 weeks. Let me tell you some words about the first contraindications. These are from EMS, so companies' contraindications. Yeah, treatment over air-filled tissue, like gut, of course. There's nothing what we want to treat. Then we need to think about how deep is the wave entering the tissue. So if we treat the upper back, the lower back, the whole back, yeah, back, always think about is the shockwave really able to reach the lung? Almost 90% it's not able to reach the lung. If you, for example, reach the skin around the lung, then the patient starts sometimes to cough. So I just need to change the position. But I don't destroy any lung tissue from this area by using radial devices. Treatment of torn tendons, if it's more than 50% injured, yes. Treatment of pregnant woman, of course, I will never treat a pregnant woman in the lower back. But why not treating a pregnant woman when she's suffering from a heel spur? This is a very good way to treat these people. Treatment of persons under the age of 18, except Osgood-Schlatter disease. So Schlatter disease is an indication from the company itself. But of course, what is the thought behind all this? We don't know what is happening in the growing zones of children. So we never shoot in growing zones of children. So epiphysis, we don't shoot. Osgood-Schlatter, the tuberositas, is an apophysis where we are allowed to use it. Yeah, and if the child is suffering from a muscle injury, whole muscle, why not using the shockwave as long as we don't reach the growing zones? The only thing you need to keep in mind is, according to law in your country where you live, do I need to inform the patient, let them sign? That's what we do in Germany. Inform them about contraindications, what can happen in what tissue, and then just let them sign. But basically, this is the first four are just a kind of relative contraindications. Yeah, you just need to keep this in mind. On this point, I always want to mention trigger points because it belongs to the topic about substance P, what we had in the beginning. You see this guy sitting at the airport waiting has a lot of trigger points. Most of them are caused by an acute or chronic overuse of muscles. So what you find in these trigger points is kind of inflammatory mediators, neuropeptides, which basically leads us to substance P and the pain circle and neurogenic inflammation circle again. So this is why it's working perfectly. We find substance P in these trigger points. So it's one of the best ways to treat trigger points without pressing with our thumbs or anything else in these trigger points. 300 to 400 impulses in each trigger point are very sufficient. So this is basically how we can treat it using EMS laser device, using an EMS shockwave device. We are like working with a cooling device and then give them some exercises for home. What are the proven effects, basically, of a shockwave? What else do we find in the literature about level 1 studies we have? We know we can increase the lubricin and tendon gliding with the radial shockwave. Why is that important? If you have got a patient suffering from a fracture, for example, using a shoe or crutches and can't walk, after removing, he is immobile and the tendon is not gliding. So this is why we need to increase the tendon gliding. We can improve the blood supply by newly formed capillaries. That's why it's working for ED, for example. Just takes a longer time than all the other injuries, but it works. New bone formation. We know that we can create new bone formation in the cortical bone. Yeah, even in osteoporosis, it's working. It's a clinical indication. We don't need to worry to destroy anything. It's an acoustic wave, not a mechanical wave. Yeah, and also after the primary fracture healing for proliferation and differentiation of osteoblasts, we're using it. So after 6 weeks of primary bone healing, we still use shockwave to make the bone stronger again. Let's come to the cases, yeah, because they're even more exciting and they're even more interesting, yeah. As a short information, I need to make a short break because my laptop is just messing up everything. I need to make sure that it's not running automatically. Hope it's gonna work now. Sorry for this short interruption. Let me say you something about the cases and application, because this is quite important. Basically, you will see how I was treating certain cases and certain injuries. But this is not a kind of real protocol we have in this case. So the main protocol, how to use the shockwave, is setting up the device up to 20 to 25 Hertz frequency. Why is that? That's we already had before, because we want high energy delivery into the tissue, and we know therefore, and with this frequency, we get the highest amount of energy in the tissue. Then setting up the pressure input in the device, always up to the individual patient's pain threshold. So whenever your patient feels a slight tolerable pain between 6, 7 out of 10, then you're working perfect on the right spot. Why is the pain threshold important? If your patient's not feeling pain, we don't get the release of substance P, and therefore we can't work on the neurogenic inflammation of the decrease and reduction of neurogenic inflammation. So what we need is pain. Therefore, it doesn't work to use local anesthetics. Using local anesthetics before treating with shockwave will shut down the pain receptors, and therefore we don't get any release of substance P because the patient is not feeling any pain. So never local anesthetics. So setting up the device 20 to 25 Hertz frequency, pressure always at the patient's pain threshold. Then there comes, of the audience in normal situation, there comes the question, yeah, but how many impulses do I apply? Impulses are defined by your individual patient. How long should you treat? Easy answer, as long as your patient feels better afterwards. So when you read studies, you will see a lot of numbers like 2,000, 1,500 impulses. This is just the only reason that we need a definition of every patient, how many impulses to apply. But basically, the number over the last years increases a lot. So a normal treatment will last about 3,000 to 5,000 impulses. When we need more or higher amounts of impulses, I will tell you this during the cases we will do to show you what basically is changing in the tissue then. How many treatments do we need for all of these indications, for the basic indications we have? 3 to 5 is a number which always works fine. So basically we say every 5 to 7 days, one treatment, 3 to 5 treatments in total. This is just the rough number where I would say 80% of all pathologies work. Sometimes, of course, you will see this, you have really severe chronic issues, patients suffering, for example, from a heel spur since 2 years or tennis elbow since 2 years. And these patients probably need 1, 2, or 3 treatments more. This is individual, yeah? Let me say one sentence about when the first treatment is not leading to a positive effect on the patient. Don't worry. Always keep in mind, sometimes it takes time until you get a proper reaction. And make sure that everything what you did is right. So think about, have I been on the right spot? First question. Second question, did the patient really feel pain? Did he really feel 6, 7 out of 10? Yeah. Probably you can't find this out in the first therapy, but then don't worry, try the second one and you will see it's going to work. So let's concentrate on the cases and talk about these cases. One of the most important things I'm treating in everyday life, because of a lot of athletes I have, are all kind of muscle injuries. And I don't care if it's a partial rupture, muscle strain, fiber rupture, whatever. So if you look at this, most important study done by James Morgan, the guy I already mentioned before from a local football club in Germany. He treated all his athletes with muscle injuries with radial shockwave. So type 1A, type 2B, type 3B, which appeared in this season. And you can see that the layoff time could be reduced by almost 54%, and with the biggest injuries, even 23%. On the right side, you can see one of my first league soccer players I was treating with shockwave, how the injury changed during the treatment within 10 days. You can see a reduction of edema of the fluid in the tissue. This was the protocol basically used for muscle injuries. So this is just not for every patient the same. It was just used for 3A soleus muscle tear, but it can give you an overview about how fast you can increase the load and how many impulses were used. You can see that almost for every treatment, 7,000 shocks were applied at a pressure between 2.5 and 3.4 bar. You also can see that we have a decrease of pressure in this area and in this area. Yeah. This happens because the feeling of the patient is changing. More active pain receptors, the load change. So this could be a normal reaction. This is not meaning that the injury is getting worse. But what you can see is that after 4 days starting swimming, 8 days already bicycling, 13 days running, break, running, another 2 days break and intensive running, also followed with an exercise program. So this is a rough amount, how many days a treatment and a training lasts for a 3A soleus muscle tear. So we've got a total downtime of 21 days. This was one of my players, yeah. Johnny now playing in first league in Austria since 5 years, never suffered from a muscle injury so far. Was one of my first severe muscle injuries I had. So you can see on these pictures the big muscle injury in the tissue. You can see the fluid inside the tissue. So we started treating this guy immediately with Price, yeah, on the pitch. Then 24 hours after the injury, we already started with a shockwave. You see, this was used with the older device, 36 millimeter applicator, 2 bar pressure, 3,000 impulses at a frequency of 20 hertz. We continued the treatment for 14 days daily, then every 2 days. He was completely pain-free after 3 days, as you could see in the table before. Cycling without pain after 7 days, after 13 days running. From day 25, we started with the team training. We had a total downtime of 35 days because it was a severe 3B injury. I told you that he was never suffering from a muscle injury so far anymore. But why is that? Because the prevention of muscle injuries is even more important than treating the injuries. This was done with the first 4 teams of our local soccer club. What you can see is that we had severe injuries before using the shockwave as a preventive tool. But after using the shockwave in May 2016, you can see in the green numbers how the decrease of these severe pain muscle injuries is going down. We also use it for neurology and spasticity. Why is it working with these kind of patients? What is happening with these patients? Injections of botulinum toxin are not superior to shockwaves to treating spasticity, yeah? And they could last longer than the effects produced by botulinum toxin. So our patients getting botulinum toxin come back early to get another injection, but doing shockwave, it's even more relaxable. And why is that? This could be is one of the proofs done with a nice study. You can see on these pictures what has basically happened. The localized destruction of these end plates in these hyperregular muscles can cause exactly these effects, because then the density of acetylcholine receptors is getting less. So this is one of the effects why this might happen. On this picture, you can see one of the guys I'm treating at spasticity, and after 10-minute treatment, you have no spasticity left with this guy. So he's treated regularly, arms and legs, and you get perfect results. Let's talk about fractures. I like fractures because they are really interesting and you can perform a lot of good healing. So this was one of my professional players suffering from a Jones fracture, metatarsal 5 fracture on the right, as you can see on the pictures. I always like that the surgeon is making the surgery with a screw, because then the shockwave can reach all areas of the fracture. Whereas when I'm using a plate, I can't shoot through the plate, so I need to shoot around. So what you see is that on the first day, we are doing manual lymphatic drainage in hospital, some cooling devices, but already start on the second day doing shockwave for lymphatic drainage, for reduction of pain, swelling, then do it daily from day 4 because it's a professional player, full contact on the fracture, and on day 11 we already can reduce it. After 4 weeks, you can see in the control MRI that the bone already starts to heal. Full body weight on the foot was possible. We could start cycling because we know this fracture is going to heal. After 6 weeks, another control X-ray, you can see the consolidation of this bone even more. Yeah, so we can start with training with the ball, increase running, and after 11 weeks downtime, he's back on the pitch. Also, fresh fracture on the hand is working perfectly, as you can see here. Or if you find more complicated versions, a friend of mine with a complicated ankle trauma, you see tibia bone fracture, fibula bone fracture, rear and front syndesmosis fracture. But I just want to show you how strong the device is. So and on the 10th of May, we started doing the shockwave. Yeah, you see the pictures. This was our first treatment we did. There, we definitely need 15,000 impulses to treat the whole area, to reduce the swelling and the pain and reach all these different areas. But the result is impressive. So if you just have a look, what is basically happening 2 days after the treatment. 2 days after the treatment. And another 3 days after the second treatment. So 5 days in total. This is the result, what's happening to the foot. Completely pain-free. Of course, he's not allowed to move, but this is a perfect result. If we go one step further, according to fractures, it makes sense to look at non-unions. We've got 2 nice studies showing that it's working with non-unions. Of course, I can show you some cases of these delayed fracture healing in the beginning. You see, this is the result. This is the result after 6 weeks after surgery. And if you go one step further, yeah, after 5 treatments, radial and focal combination, you can see calluses appearing, yeah. And after another 5 treatments, yeah, you can see that the bone is already almost healed. So within just 10 treatments, yeah, less than 8 weeks, you can perform a result like this. Second one, in this case, we're talking definitely about non-union. 8 months after surgery, after complicated fracture, we find pictures like this. This patient was sent to my practice because of a non-union to increase the healing as a last chance before another surgery. So 8 months after surgery in March 22. After 10 treatments within 4 months with a focused and radial device combination, yeah, you can see a full consolidation of the muscle. And it's important to use both devices in these cases, yeah, because we won't need so much energy in the fractured area to increase new bone formation and bone healing. So if you think of the differences of radial and focused devices, you know why we definitely need to use both. Ligament ruptures, a very common topic, also not just in professional athletes, but also in every other patient's problems. German soccer player, ankle distortion during a season game. You can see the ATFL rupture, massive joint swelling. Of course, there must be a joint capsule problem. We started with the acute treatment within the first hour, high power laser cooling devices. But after 12 hours, we start doing laser and radial shockwave. You see 5,000 impulses, frequency, as I said, pain threshold 1.5 bar. Then after using the cooling device, after 24 hours, walking with full load is possible. No swelling anymore. We did an MRI after 1.5 days after the injury. So after we already started doing shockwave, we could see a complete ligament rupture, but just slight swelling left in the joint, which already shows that shockwave starts to work. Daily therapy up to 3 bar, full quick increase of pressure. You can see the difference here. We are already using a 50mm applicator, some cooling device afterwards, and we have a total downtime of 19 days in total. Just to show you another picture about the reduction of swelling with this, we have on the left side, we have the first picture how it looks like after the trauma. On the right side, we have what happens during a certain amount of time, kind of overuse. Yeah, we get a secondary lymphatic edema, which we need to treat. It's stuck in this area where you can see where the sock basically shuts down the lymphatic drainage of the foot. So we need to work on this area a lot. So this was about 12 to 15,000 impulses on the foot, but directly after the treatment, it looked like this. And we can make these drainage visible, in this case with a knee after an ACL rupture. You can see the heating on the left picture, and you can see what happens after shockwave therapy. You can see everything is cooling down, of course, also a bit because of gel, but what you can see is that the vessels, the blood vessels, are working. You can see how they start transporting everything out of the tissue. And this is something we can make visible. with a thermography device, but this is something which you can even see in this picture. So you can see how the vessels come forward, how they start to work. Yeah, and this is something which immediately happens during and after the treatment. Bursitis capsulitis. Yeah, of course, a lot of pain, a lot of neurogenic inflammation. Yeah, this is what the elbow looked like. We had a spur in the elbow, yeah, which caused a lot of pain and inflammation with this cyclist, professional cyclist. So we did shockwave on the elbow, as you can see on the right big picture, some cooling application, and this is the result after 4 treatments. You can see no swelling left, no neurogenic inflammation, and this is not coming back. Chronic polyarthritis. This is a perfect way to treat in combination with a laser, but it's the only way to treat with a radial shockwave because the focal just is too painful and goes too deep. So this was a 60-year-old patient with severe pain attacks since 28 years using painkillers, several deformations on the hand. Before the first treatment, I made pictures to show you how the swelling was. And basically what's happening in a very short period of time, in this case, after the second treatment, 4 days later, you see how the hand basically changed. You see the color is changing, range of motion is changing, swelling is changing, yeah, mobility is changing. And if you check out what is happening, if we go on, you can see how it's changing in the hand here and here. So this is the result after 15 days with a total number of 5 treatments. Open wounds with or without muscle injuries. This was a tailor's toe. So basically you can compare it to hallux valgus, which appears very often with female. So you can see that it's very painful, 7 out of 10, almost no weight bearing possible. We opened this wound up to clean it, and then we started doing the treatment like this. So you can see we use this is a way how to treat it. We're using disinfection fluid, put some plastic foil around it, then use gel, and then applying the shockwave. And this is how it's changing within the treatments. After 1 day, it looks like this. After 2 days, we can see this. Day 4, and after 1 week. But the most impressive result is he's completely pain-free after 12 days. The wound looks like this, but the most important thing is we have got very soft scar tissue. So it's looking completely different and you can start the training. But even if you find more severe injuries like this, without any muscle or tendon injury, it's just a soft tissue injury. After a certain amount of time after the trauma, we get this inflammation signs in the very beginning. So 14 days after trauma, this inflammation appears. Then we applied shockwave for another 16 days in regular every 3 days. And the result at the very end, as you can see on this picture, is full mobility, full range of motion, no inflammation sign, soft scar tissue. This soccer player already can walk and can run. Low back pain, also. I think one of the most important injuries in our society we have. This is the first study showing that even unspecific low back pain can be treated very efficient with shockwave. So it's just a local treatment where you feel pain. But I will show you how far shockwave is going by now. So if we are concentrating on kinetic chain treatment to treat lower back pain, I show you this guy. He's one of my hockey goalkeepers after hip surgery. Very painful still. You see the difference in extra rotation of the hip, which we can see in the Patrick sign. And what he tells us is the same what these patients show us. So extra rotation problems with low back pain patients. Pain going over the glutes, alongside the leg, the thigh, and a lot of pain going down the back muscle area. So a treatment to loosen the whole kinetic chain up may improve range of motion and decrease pain is using the shockwave device in the inside of the malleolus, applying just 3,000 impulses in the very beginning, yeah, at 20 Hertz frequency and 2 bar pressure. And this is the result at the end. Why is this working? Let's go back to the slide again. Because we're affecting via the flexor tibialis posterior muscle, the whole kinetic chain up to iliopsoas muscle, which is one of the most important muscles for low back pain. They always have, all low back pain patients have psoas problems. And you see pain is decreasing and the mobility range of motion is the same. And this is a quick lasting effect which you can provide with every of your patients. I'm going to tell you something about our network, and then I want to show you something about tips and how to use these, because it's quite important to know what all these applicators are about. So we've got a huge network. So by looking over our participants for today, you can see that there are so many countries involved today, from North and South America, Asia, Africa, Germany, Europe, whole Europe. We have so many different participants today, which is great. But this also shows how the network basically is working. Yeah, you will see this also in our after communication. So you will get the presentation on demand when you need it. Yeah, so you can look through the slides without the problems I had in the beginning with my laptop. But you also can see that there are many more people involved. And so if you have application questions, if you have interesting cases you want to share, or just talk about issues about how actually applying shockwave, use this whole network. Yeah. If you spread your practice around, try to get certified by EMS so that your practice can be found in the internet on the practice finder on the EMS website. So there are so many opportunities to stay in touch. Use the EMS website to look through all the possible indications about through all the videos, the studies you can find there, and share it. I'm traveling around everywhere, yeah. So use all this, yeah, to get always new information. Probably we're going to meet each other. And before I end and come to the practical part, look how people needed to do shockwave many years before knowing that the DolorClast device is a good alternative. Yeah, low energy shockwave. Yeah, 1 Hertz frequency. And I'm not sure if you can reach 1 bar pressure on this patient. So I'm very happy that we can use the DolorClast device and getting very quick and efficient results. You can see on the lift picture also professional athletes, yeah, when they're not happy to wait on me because I am a bit late, yeah, starting using the device like I did it before. And this makes our team a very successful team. Before we come to questions and answers, I switch to video mode, get the tips, and then let's talk about the tips. Let's talk about your questions and afterwards. So I get the tips. Hope everybody can see me. Now, I saw a lot of people already using the DolorClast device. So what I want to show you is we've got several different tips. Yeah. I know that a lot of competitors, a lot of other devices always say you need to change these tips every time for every kind of indication. This is something which is definitely not necessary with the DolorClast device. I told you the most important thing is energy. So we want high energy delivery with every single shot in the tissue. And by applying shockwave, we always need the pain's individual threshold, pain threshold. So whenever I have ever reached the individual pain threshold, energy delivery is sufficient because then I get the release of substance P. So I'm using the 40 millimeter in the beginning, for example, reaching the pain's individual pain threshold. But after 2 or 3 treatments, I'm at 4 bar and the patient is not feeling any pain anymore. What do? Decrease the diameter. I can make it half with this one, or even a bit smaller with this one. But by decreasing the diameter, the concentration of energy on a smaller surface increases the individual pain feeling again. So I get more energy on a smaller area. After working with this, another 3-4 treatments, I'm reaching not the individual pain threshold of the patient anymore. So I need to decrease the diameter again. So I've got several opportunities to decrease diameter to reach the individual the patient's threshold. Then we have got 2 50 millimeter applicators like this. They are doing exactly the same thing. The shockwave is leaving on top of the tip. I have with a longer trigger point applicator, I have the possibility to press a bit more and go deeper in the tissue. But basically doing exactly the same thing. Then I've got the 10 millimeter applicator, decreased diameter again. And then I've got 2 special ones. I've got a very, very small one. This one is behaving a bit different because the tip is so small, I'm not reaching enough pain receptors to really increase the pain feeling of the patient. But I have concentrated energy. With this energy, this tip is perfect for treating scar tissue. So I can put a lot of energy in scar tissue and get it smooth and soft. Everybody of you treating knee patients after surgery knows that especially the lateral bound of the knee is always causing a lot of pain. So start immediately. Then we have the concave one. Hope you can see it. With a concave one, you can concentrate a bit more energy that the wave is not leaving the tip like this, going a bit more down, and you can concentrate the energy a bit more in a smaller range of motion. So again, because this is the most frequency questions I get for after all lectures and during everything. A treatment protocol is every 5 to 7 days, 1 treatment, 3 to 5 treatments in total. Frequency 20 to 25 Hertz. Impulses, it should be the pain feeling for the patient, the feeling of the patient at the end of the treatment should be better. So 3,000 to 5,000 impulses, and choose the tip with you can get the patient's individual pain threshold. This is the most important protocol you need. Good. Well, very quick because of my laptop problems, but all the informations were on site. I would say because we're so many different people today, we concentrate on the questions you have. Don't forget, there are no stupid questions. So what I want you is ask all the questions you have as possible. I start with the ones already appearing on my question and answer button. I read them loud and then try to answer them when possible. Can I ask about contraindications to shockwave? Would you consider anticoagulants RX as an absolute contraindication to shockwave? It's a very complicated topic, talking about medics and anticoagulants. Basically, what I do in my practice, because there are so different medics, is if I really want to do it, and I really don't, most of these medics don't react, and these patients don't react. You have a lot of patients who don't even know that they're taking stuff like this, yeah, by just treating them. So I would always consider doing a test treatment on a small area, checking out if anything is happening, yeah. If possible, stop using the medics for the short period of time of treating, yeah, but you need to be on the safe side. Basically, no severe things can happen, but you need to be on the safe side. Do you use ultrasound? I personally don't use ultrasound, but it's a good opportunity to check everything, especially when you have an MRI of a tendon rupture. You don't know how much of this tendon, for example, is actually ruptured. Is it a contraindication to treat? For using a focal device to define how deep do I need to go into the tissue. Yeah, so within a range of 4 centimeters, I don't really need doing ultrasound. Because I'm treating the whole area. Using the focus device, it could be really important because you need to define how deep the focus shock wave needs to enter the tissue. So yeah, it's quite important. Please remind me again the amount of pressure you put. I think I just say it again because I told you it's important just in case. Always the amount of pressure until you reach the patient's individual pain threshold. So 6, 7 out of 10. This is a pain the patient can tolerate. It's individual because every patient feels another pain, or the pain more or less. But with this threshold, you get the best results. I have a previous generation DolorClast Smart 20 with Evo Blue. I was previously instructed to use 12 hertz. Is 20 hertz now the recommendation for all conditions? Is 2,000 impulses no longer sufficient? According to the studies, which most of them have been done with about 12 hertz frequency and 2,000 impulses. This is study-based, yeah? And it's a sufficient treatment. It's working with this kind of frequency. But over the last 7 years now, we found out that applying even more energy in the tissue is more effective. That's what we had before. High energy shockwave is more effective than low energy shockwave. So if with every single shot, you get more energy in the tissue, and we saw this in the recent study, yeah, where we can see the energy delivery according to the frequency, we can just apply more energy in the tissue. Basically, frequency is not relevant for the treatment outcome. It just defines first thing, the higher the frequency, the lower the pain feeling of the patient. Yeah, so if you will use 2 bar pressure and 12 hertz on a patient's elbow, and then increase up to 20 hertz, 20 hertz, he will definitely feel less pain. Okay, so by setting up the frequency up to 20 hertz, or if 20 is the maximum, I would always recommend 18 to 20, but 20 is what I'm using most. 20 hertz frequency, I just have to play with the pressure input to reach the threshold. Yeah, if you have got 12 hertz and you're going up and reaching 4 bar, for example, yeah, you always have the frequency to play with. So stick on one frequency you like to treat. I always suggest 20 hertz frequency, and then just play with the bar pressure. Impulses are no longer sufficient. It's the same thing. If you put in more impulses, you can see that they're improving more. Basically, it's like in the studies, they did 2,000 impulses, stop the treatment. What we are going to do is doing 2,000 impulses, then the pain feeling is getting less, and then we already increase the pressure. Then we get more pain receptors. This is, think of the chili again. Yeah, if you eat a chili, your mouth burns and it's getting numb. If you eat a more hot chili, it's burning again and then getting numb again. If you would eat the first chili again, then you don't feel any pain anymore. So by increasing, we just release even more substance P and have more effect on the neurogenic inflammation. Are there benefits of shockwave on nerves? We have effects on the nervous system. This is something what we know, that cavitation has effect on nervous systems. Then we know that a lot of nerves have also a kind of fluid environment around, which we can improve. Yeah, but basically on a real inflammation on the nervous system, I never use it. Why is it okay to osgood and not to other grow plates? Because these structures are different in anatomy. We have got epiphysis, which is at the end of the tibia bone, for example, a femoral bone, to induce the growing. The tuberositas is a so-called apophysis, where we actually want to accelerate the bone formation, which we don't want in young ages in the growing zones because they need to grow. Yeah, but in these insertion of tendons, apophysis, we actually want to accelerate the bone formation to get rid of the inflammation in this area. So anatomy structure apophysis is allowed because it's no growing zone like epiphysis. Morbus Sever disease, yeah, it's also an apophysis, no epiphysis. And there are different anatomy structures. So that's why it's allowed to do it with the Schlatter disease. Headaches using the shockwave in the suboccipital area. Dr. Duck, hi Dr. Duck. Nice that you are here. Just met. So headaches. We are going, I hope you can see it. Occipital area is the border. We don't go higher. So occipital area, we are allowed to use it and it's proper working. We have got a lot of trigger points in this area. So suggestion for proposal for treatment. We're using the trigger point head, yeah, so which is easier to reach just a small trigger point. You need to set up the pressure very quickly because I said before 300 to 400 impulses in the occipital area, suboccipital area are enough. So staying between 1.8 and 2.4 bar pressure in this area is sufficient to release the trigger point in this area. That's how you can release a lot of tension, especially for headaches. Then if you're going down the muscles, paravertebral, you can use the bigger head to release the tension in this area. I hope this is a sufficient answer. Otherwise, please just text me. Please go through the treatment protocol again. Of course. Uh, 3 to 5 treatments in total every 5 to 7 days. Set up 20 hertz to 25 hertz frequency, pressure, pain threshold of the patient. What is your treatment protocol for chronic plantar fasciitis? Local painful area, the protocol I just mentioned before again. So frequency, how often, how much pressure is the same. What I additionally treat is I also try to treat the calf. So whenever the plantar fascia, a heel spur, Achilles tendinopathy, I always treat the whole system. So always plantar area of the foot, calf, Achilles insertion. This is quite important. Next question. What would you advise on peroneal brevis tendinopathy? It's exactly the same thing. Yeah, I need to check the whole muscle area. I need to check the insertion, and then treatment protocol is exactly the same with every tendinopathy. I always treat it the same way because what I need for proper healing is always the same. For proper healing, I need a reduction of neurogenic inflammation and reduction of pain, which are correlated very close together. So by reducing the pain, neurogenic inflammation is going down. If neurogenic inflammation is going down, pain is going down, and so on. If we get rid of neurogenic inflammation, the healing process can start. So same protocol, basic protocol as with all kind of indications, and then just stay on task. Why is physiological cavitation in the tissue important? This is not, they didn't find out so far everything, but they know that the biggest part of this is mediated by cavitation. When these cavitation bubbles appear, they get hit by the next wave. It's a kind of jet stream, and these bubbles burst. And this burst is causing a physiological effect in the tissue. That's why this is working. The burst of these cavitation bubbles is causing the reaction, basically. On the MS website, the indication protocol suggests 8 to 12 hertz with 2000 impulses over one area. This is a bit conflicting with your recommendation of 20 hertz and 3000 to 5000 impulses. Yes, this is the same thing with indications and contraindications. Yeah, I'm as a practitioner explain or show you the possibilities of how we are treating these kind of injuries and what results and quick results we get. The EMS website needs to be filled with study-based information because it's a company. Yeah, and um, also they will change these informations on the website in soon. So basically, the company always needs to be stick with the contraindications I had before. Yeah, this is a basic contraindication, but I explained you, yes, pregnant woman, not in the lower back, but why not for the heel spur? So companies' recommendations are always a bit different to practitioners' recommendation. Effects are better. So 8 to 12 with 2000 impulses is study-based. Practitioner-based is what I just told you. And you will find these informations, I hope, soon on the website because it's going to be renewed. I just leased my first shockwave instrument, a Storz one, but now after you showing the energy release example, I might have a bad machine. You know, it's always a bit difficult. I try to stick on the everything, but yes, unfortunately it is because you can't perform high energy. So I don't know where you leased it and how you can probably change it. This is basically, I would suggest check your leasing contract. Talk to local distributor who is in charge for EMS because they know how this is going to work. Yeah. My personal opinion, try to get rid of it. Sorry, I tried to be honest. Is there a contraindication for heart conditions? Previous training has suggested this is a contraindication. It depends where you're going to treat. Yeah. So if you have a pacemaker, never over the pacemaker. If you have a kind of heart condition, you're going on the left side, you're going on the upper back. I never had heard of any problems. You must think of these devices are strong for musculoskeletal issues, but if you look at a shockwave destroying kidney stones, it's a very these shockwaves are all weak. Yeah. So basically, where do you want to treat, and where you are really frightened of probably causing a bad effect. So if I have a heart condition, I wouldn't treat left side here. Also, I know that the 4 centimeters are going really deep in this area. So I don't see any big problems. Heart conditioning, what can be expected? Secondary, yes. So if you have thrombosis and you need to take care that this is not going to the heart, never do it. Yeah. What is the cryo? I'm using a lot of cryo devices because I like cryo devices. We have a game ready, we have a hyperbaric CO2 cooling device. It doesn't matter. It's just about using cooling application. And because time is money, I'm using a device which just leads 10 to 12 seconds, which just makes my treatment easier. So basically, cooling, yes, cooling after shockwave, not before. Think of local anesthetics. Cooling the area before will decrease the pain's threshold. So release of substance P might be difficult. So best effects, best results, cooling after. How much pressure should be applied to the handset? Do we need to apply as much pressure as possible, or is just holding the device, the skin? Ah, yeah, okay. No, you don't need to put a lot of pressure on the handpiece. Just holding it slowly on the skin is sufficient to get the wave into the tissue. There are two things where I need a bit of pressure. First, when I need to go deeper. So when I want to reach about 4.5 to 5 centimeters, if I use more pressure, then I can reach deeper tissue. Second, if I use it for manual lymphatic or for lymphatic drainage, I always try to get slight pressure movements up and down like this. So then I use pressure upwards, slightly back, pressure upwards. But basically, the wave is entering the tissue up to 4 centimeters if you just put it slightly onto the skin. What is treatment protocol for Achilles tendinitis? We talked about this. I hope this is sufficient by now. If not, then text me, please, personal. Not a question, but thank you. You're very welcome. Yeah, very welcome to the United Kingdom. Storz Master Pulse 1, there is no difference. These Storz devices don't create any energy. Sorry, Ingrid. What are the biggest complications that have occurred with the Stoßwelle? So I'm doing shockwave since almost 9 years now. I'm doing 25 to 30 million impulses a year, just me with my device. The severest thing I ever had is that the patient came to me after 3 days to the second treatment and said, the first day after this treatment was really, really painful. The right answer to this is yes, that's a good sign. I'm happy about this because then I know the healing process already starts. This can be, yeah. So this doesn't mean that we need to stop immediately the treatment. So to be honest, if you just concentrate on what you're doing, if you're thinking of your contraindications, yeah, basically we don't need to think of indications. If you all think of what is EMS DolorClast shock, radial shockwave, or focused shockwave, what are they doing in the tissue? Pain relief, reduction of neurogenic inflammation, then to start the healing process. So activation of stem cells, release of growth factors, muscle relaxing effect. So if you think of these things, you have a patient coming with pain syndrome, whatever. Ask him, where's the pain? When is the pain? Check the contraindications. They say, yeah, he has pain. I want to reduce the pain. Of course, he must have an neurogenic inflammation in this area. So I need to treat these two. Do you have a muscle problem? Yeah, range of motion, whatever. Most of range of motion problems come because of pain and inflammation. So yes, I need to treat this. Then you have your indication. Yeah. Don't think of, oh yeah, it's just calcifying shoulder, it's just Achilles tendinopathy. No. Think about what your patient actually is suffering from at the moment. Then check if am I allowed to do the shockwave in this area? Yes, then go for it. Then you have your indication. Then you have your basic protocol, how it works. Yeah, frequency, a rough number of impulses, pain threshold of the patient. This is the easiest thing, and then you don't get any complications. Is the analgesic mode effective considering you mentioned highest free? The analgesic mode on the new Radial device is doing two things. So if you have severe pain, patient hand, for example. So you start with a 40 millimeter applicator at 1 bar, highest frequency. And he's still not able to tolerate the pain. It's always over his individual pain threshold. You have the opportunity to use an analgesic mode, number 1 or number 2. Analgesic mode number 2, I always recommend because of the higher frequency, but you can use both. What means that the pressure is slightly beneath 1 bar, about 0.9 bar pressure. So you can reduce the pressure a bit under 1 bar, and then probably you are able to use the shockwave. Another way, just to show you, yeah, if this is not working either, yeah, what you can do is just move faster. If you stay on one spot, all the energy is always going inside. It's painful. If it's too painful, move it quickly. If you move it more quickly, then the pain feeling is less. But always think about, then I definitely need to do some more shocks to get more energy in the tissue. And then it's going down, and then you can stay on it. Can you treat plantar fascia or Achilles tendon tear with a radial shockwave if not a full rupture? Yes, of course, you can. Would you use high power laser GDT protocol with the ESBT? Yes, of course. Short sentence about the laser, the EMS high power laser, because it's a nice thing to make combination, as I just said with the pain. So high power pulsed laser, 905 wavelength, has the ability to have an influence on the pain's threshold, but not like local anesthetics. It's a different pain circle. Yeah. So if you're using the high power laser and wait between 15 and 60 minutes, you can apply higher energy levels because 905 wavelength is working like local ibuprofen. So you can apply higher bar pressure and therefore higher energy. So it's an opportunity to reduce the pain feeling in the patient to apply more energy. I usually, do you move the applicator a lot during treatment or do you keep it still for certain amount of impulses? Usually I really move the applicator because there's not only the one and only spot we need to treat. Yeah, if you think of a heel spur, it's not just the spur itself, it's a bit more left, a bit more right, because I need to reach the whole area where the neurogenic inflammation is. And this is not only the spot where the heel spur is. So I definitely move it around, concentrate on the most painful spot and try to reduce all the pain, the whole painful area. So I am a kind of mover, applicator mover. For lymphatic drainage, would you then suggest a lower energy? No, 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 because I still have these processes in this area going on. So always the same procedure. The only thing is that sometimes, for example, if you have a big thigh, yeah, um, we don't really reach the painful area. So sometimes we reach huge swelling in the leg, for example, with 4-bar and the big applicator and don't reach any pain because it's just not possible. When the pain then is the lymph swelling is decreasing, then I'm suddenly reaching certain pain levels, which means then the pain can come back and I need to decrease. But basically, always the same settings for lymphatic drainage, for muscle injury, for everything. So I already mentioned. So many really good questions. You're a brilliant audience. I think when we're not quite sure that we can answer all, just some more important. Is it possible to ruin a nerve? No. You're treating so many areas in the skin where you have hundreds of nerves around. So why should you ruin a nerve? And again, this is nothing which is strong enough. I don't answer the questions about the special settings anymore because they are just minutes ago and we already mentioned a lot. Do you use the smallest tip for occipitals? No, I'm using, in main cases, I'm using 50 millimeter tip, which is one of the easiest one. Yes, I'm using it for shin splints. I'm using it very often for shin splints, IT band syndrome, and all these things. How long would your treatment last for the foot and calf? Depends on the frequency, of course, but always have these 3 to 5 thousand treatments in mind. Then you can calculate it. What about the muscles that sit posterior to lung fields? Again, the lung is a not so complicated tissue as everybody always thinks and fears. Basically, if you're treating the lower back, the upper back, and your patients start to cough, you know that you're irritating some kind of not really lung tissue, but the skin around the lung, or the vibrating is causing irritation in the nervous system. So then they start to cough. Tell your patients no problem if you cough. I always tell them when I start treating, and then I just need to either decrease a bit power or change the location where I treat because they're just overreacting, but you don't destroy anything. Almost done with the questions. How fast do you move the probe? Doesn't matter actually how fast. You just need to think if I'm moving it really fast, then I just have a problem hitting, getting a lot of energy in the painful area. So for manual lymphatic drainage, I exactly move it like I want to do a manual lymphatic drainage with a slight pressure. For all the other indications, the range of motion, basically where I treat, is a small area. Yeah, so I concentrate on this and try to reduce the pain in all these areas. For follow-up, post-treatment is still recommended to be carried out 12 weeks after the final session. Is 12 weeks the window for full therapeutic benefit? can calculate this. Basically, what I always say to my patients, if I'm doing 3 to 5 treatments in total, once a week, it's 5 weeks. Then I say the shockwave is working after the last treatment at least 3 to 4 weeks. So we are around 8 to 10 weeks, I would say. So I don't mind if it's 12. It depends on each patient. But basically, we know that shockwave effect is lasting 3 to 4 treatments and still working. Why is shockwave is an important question, a contraindication to local cortisone, because we don't know what actually is happening with in the tissue. Cortisone is a cell poison, so it has the ability to destroy tendons and also muscles. So if you have a local injection at a tendon, yeah, and you have a tendon rupture afterwards, you have no chance to prove that it was not the shock wave. And it's really, really difficult because we are gaining so much effect in the tissue. So that's why we really want to stay away. For example, if you have injection in the joint, shoulder joint from the back, you can definitely treat the muscles and tendons around it. I will choose one more questions because we are already late and people are leaving. So don't worry if your question is so many good questions, but if it's not coming, reach out to your local distributor from EMS where you got the device, or stay you want to stay in touch, write to EMS. You will get all the information you need, all these questions. I will answer them if you write me. This is really, really no problem at all. So last question from Bruce, because it's the last question. It's a funny question because it's a good question, but a funny story behind it. How many patients, have you had any patients suffer from a sympathetic reaction when you are trying to reach their pain threshold? Basically, not really when I'm trying to reach their pain threshold, but there are several really sensitive spots where it sometimes really can happen. So what I like to treat is large intestine 4, and I have also a spot here in this area at the elbow. And these two spots are very sensitive, and sometimes you can really have some a sympathetic reaction on this area. So that's why all my patients, whenever I do shockwave, lie on the table. I just need to know this. So sometimes this definitely can happen, but it's not a severe and long-lasting reaction, but it sometimes really can happen. So, my friends, was really, really enjoyable. Also, I had these technical issues, and I need to try to figure out why this basically happened. It was the first time. I hope my children didn't play around and messed my PC up. So, thank you for attending. Still more than 80 people online and listening. So, there will be 2 other webinars. They will have almost the same content. We're gonna check out how many people will attend there. Then probably planning another one about how to do practical applications, so with a camera. Let's stay in touch. Write, send informations, ask for informations. I hope we will meet. Probably some of the guys attending I already met. Enjoy your evening. Thank you for attending, and yeah, take care and a lot of shockwaves. Bye.